Welcome to CareTalk, America's home for incisive debate on healthcare, business, and politics. Today, I am very excited to hear the story of Tennr. And we have the co-founder and CEO, Trey Holterman, to walk us through what is one of the more exciting AI-assisted health tech companies. Welcome, Trey.
John, excited to be here with you. Yeah.
So how did you get interested in healthcare and tech and AI? What's your before we get into what Tennr does and Tennr's origin story, what's yours?
So I guess closely sort of intertwined. To be honest, I don't have a nice storied career like you behind me. I got into this mess basically. Like all the good things, all the good decisions I made, effectively started by being made fun of by my mom. So we were starting basically at Stanford. We were operating at the Stanford AI lab. We were doing a research project, and basically, in 2020, 2021, it was like fairly obvious to folks that were playing around with the early Google Vision models, folks that were using GPT-2 where you could. It was like, okay, there's going to be sort of a very interesting unlock here. And basically every single
but at that time there were all these errors. Even then you knew that you could see the momentum of AI.
We sort of not at that point in time, to give you some context, it was like you would get people were like depressed because if you were focusing on ML, you were basically going to be relegated to working on ad algorithms for Facebook or TikTok. That was like the main thing. And then in the medical space, the only things that people were really excited about were like Andrew Ng's lab on radiology reading. So, and that's of course led to a bunch. So simultaneously, right, from both sides of it, you could see like where there was overhype, and honestly led to a massive radiology shortage, and where there was potentially underhype. And if you also remember, about 5 years ago, basically every young smart person was being told, you should really be in this thing called crypto. And we were like just trying to do anything but crypto. Basically,
actually, a bet on either seems to work out well, at least to date.
Yeah, no, and trust me, we looked like idiots for quite a few years there, and now, right, every venture capitalist is loving healthcare, and I think there's a big opportunity and a big moment, right, because there's a perfect match of the type of problems in an industry and sort of the solution technology that came about. But yeah, no, we had many a investor or what would have been an investor maybe try to convince us to go into crypto. So, anyways, we were sort of adamant that like, hey, we sort of started thinking about projects at the time through the lens of like, what would our kids make fun of us for not doing? And we were both kind of like, if we don't explore this technology, our kids are going to make fun of us for this someday. And the way that we made fun of our parents.
You seem to be very shame-driven, Trey.
Yeah, man, that is definitely come apparent here. But look, smart enough, thankfully, to listen to only the smart thing was just listening to my parents, my mom, and she would basically say, Trey, you want to solve an interesting problem. It was basically between solving her problem and solving my little sister's problem in her sorority. And my mom's problem, which is much more interesting, was she'd say, hey, why is it that when I send a patient out to the local imaging center, it feels like I'm sending them into a black hole? So she's on the family medicine side, and she's referring patients out all the time to get imaging for this, imaging for that. She's like, it just seems weird, right? It seems wrong that I call them. They have no idea of what, patient that I'm talking about. And the patient comes back in inevitably. And I'm like, hey, did you go get that imaging? And they never did, right? And so that was just kind of an interesting problem to us because we knew that, of course, it revolves massively around faxes. And, it was sort of this like interesting entrance point because we came in and when we tried to sort of solve this problem for the imaging center, so we go over to the imaging center, we weren't interested in replacing their faxes. We were really convinced that you could actually build their sort of dream solution with the faxes. And that was like really, really exciting.
So you're not trying to kill the fax machine, you're trying to automate it?
No, we've spent a lot of marketing dollars on this whole idea that like when everybody is saying kill the fax, destroy the fax, we actually think frankly the fax is a completely fine modality. It's about as good as a phone call. It's unstructured, it's messy, but both the phone and the fax are being really handled and put on rails in ways that were
resilient. Highly resilient,
robust. it's a network protocol really that like everybody adheres to. So it works. And that was always our approach. And that's like, again, our background is more from the technical lens than from the healthcare lens. And that was, I think, what allowed us, where everybody else that was much smarter than us and, much more sophisticated than us was like, hey, we are going to, do away with this fax entirely. We were like, well, look, people have had 20 plus years with solid database technologies to build around it, and they haven't been able to. What if we start with the assumption that we have to solve this fax with it? And that was really how we got started. We basically said, anybody that's got a fax problem, we are going to deal with the messiness, the 100 plus pages, the 10 patients on one thing, the 10 patients, or the one patient on 10 different docs. And it got us into the intake space. And we've effectively just taken the same platform methodology from there to work on every workflow that originates from these sort of unstructured clinical discharge notes and patients getting their documentation passed around.
What I love about your solution is you're trying to work with the healthcare basics as they are, while also trying to solve kind of a simple but really knotty problem that affects every patient in healthcare. I mean, and I think your mother, I thank God for your mother, kept you out of crypto. So step back and there's most people who are selling AI solutions like a Hippocratic Munjals, like are saying we're going to not just boil the ocean, but reinvent it and turn, water into wine as well and desalinate it. Like we are in a hype cycle where everybody who wants to raise a lot of money has to say they want to solve every large complex problem, from protein folding to automating nurses and doctors. I'm very intrigued with the fact that you're taking a very large, very knotty problem, but really just trying to solve it. How do you bring AI to solve the problem here? And what's the promise of what you can do? That's, you've raised a lot of money. So obviously a lot of other people believe you can solve this problem. And what's the value if you can solve it at scale?
Yeah, no, I mean, you bring up a couple good points. I don't think you know this, but this is funny. I actually worked for Moonjal. I was an intern at a past company of his, like 6 or 7 years ago.
No wonder you can raise money.
No, so to be honest, actually, I met him and I worked, as an intern under him. By the way, it was funny. They thought I was a spy because I asked so many questions. So they pulled me into a room and were like, all right, are you sent from a competitor? Anyways, by the way, so I met Moonjal and I was like, I came to the conclusion, I was like, I will never be able to do what that guy does. So I have to try a fully different tact, right? And again, like I think he's a great sort of visionary. I like to joke that we couldn't raise money until the company was great, basically. I was horrible at our pre-seed round, horrible raising our seed round. And then once there was customers to talk to, the Series A was super easy, the Series B was super easy, the Series C was super easy.
And who were those who were those customers that kind of validated?
So we started really in outpatient and ambulatory settings. So like that Black Hole Imaging Center, I'm not going to expose who they are, but they're a seriously sized imaging center. And we basically zeroed in on drugs, devices, and diagnostics originally. So we were working with, and we still do, of course, work with outpatient ambulatory infusion centers, specialty pharmacies, DME, imaging centers, of course, and then really expanded most recently, or not that recently now, I guess, but then expanded into more clinical settings and into health systems where it's really about making sure a referral stays in network. And even though things don't live on the faxes, they live on these sort of they live in processes that exist in people's heads. They exist on clinical charts and clinical notes. And I've always said, right, our job is to make it a very, very streamlined process to get a patient from point A to point B. And to your point, you said this, it's a solvable problem, right? We're not interested in like solving every problem. We think that if you can get patients from point A to point B when they're meant to get there quickly, effectively, without the back and forth, without the BS, we can hopefully, wipe our hands clean in maybe 10 years and say, hey, we did it. Job well done, guys. We did a good job. Let's go home.
What you're solving for is reducing the complexity and the friction of basic point to patient to place to device to whatever. How do you charge for that? And what's the benefit for the patient?
Yeah. So we charge almost always the receiving provider. So, you as a receiving provider, you may say, hey, well, I got backlogs, I got wait time and things of that nature. And we come in and we basically put the process of what we call the pre-visit patient processing process, and we put it on rails. And the work and the hard sort of reasoning steps are done by models. We have a sort of slew of these models we've built in-house to do work. We don't say
Isn't
agents.
this simple? I mean, it's healthcare, Trey. What shouldn't this be like really straightforward? What problems where does automation and intelligence actually help you accelerate and simplify the solutions?
Totally. Well, we take a lot of inspiration from sort of 1980s manufacturing America. If you looked at the processes that went into making most goods, you would say, well, look, you're going to get insane and tremendous amount of benefit from just setting up with dedicated workstations, sort of the right sort of manufacturing principles. And so everybody did that in like the 60s and 70s. And then, technology came around that really allowed you to do a bunch of novel, interesting things. But the way the workstations were set up and the sort of factory lines were set up, none of them were really optimized for the technology. The reality is healthcare today is kind of both. It's neither usually like optimized from just a workforce and workflow perspective. And then it's also certainly not in position to benefit the most from technology that can sort of make these like non-deterministic reasoning decisions. So when we come in, and frankly, we're doing both. We're basically taking this like strangely what seems simple, but always is very unstructured and requires human determination process and putting it on rails. And then you're only really automating because now that it's on rails, that part that you needed, somebody to sort of get involved, make a judgment call about, hey, well, is that a Medicare or is that is that actually sort of a BCBS New Jersey plan? But and you can tell that by the PO box.
Just the non-deterministic reasoning. Let's just pull up that string a little bit. The kinds of things that would fit in that box, I would imagine, would be benefit verification, eligibility, plan, location, multiple points of coverage, potentially geography or some behavioral aspects that would cue towards or learn from where people are failing in that referral process. Because when people don't get the referrals, the scans, the drugs they need, the benefit to the patient is actually getting through that maze of complexity that they shouldn't even be responsible for. So I guess there's clear upside to the patient, but is that the right kind of gumbo of problems that you're trying to solve with technical reasoning?
Yeah, that's absolutely like one step for payer plan selection. So you can run that. I would say the experience of the patient almost never knows that Tennr exists. The experience of the patient is simply by the time they're in the parking lot, they're getting a call and they're ready to go, getting their next appointment. That's sort of the dream patient experience that we create. And it's all enabled by running sort of the behind the scenes factory properly.
What's the hardest problem you had to solve there?
It's a great question. So there's really twofold. Like one is you have all these product SKUs that have to be built, and yet the way that you deploy into some of the most important health systems in the country like has to be configured to their instance, to how they run. And so mapping the balance of deep product SKUs and development with configurability. It's like an age-old sort of enterprise software problem, but you have to nail it to nail special. And it's sort of been put onto hard mode when you have non-determinism because things want to go off the rails really, really fast. I mean, this is hard.
Or they're totally idiosyncratic. I mean, and
Exactly.
is that the physical? That's a physical as well as technical problem because you almost have to walk through the life of the patient and the life of the provider, the life of the administrative staff to probably figure that out.
Exactly. When a processes are hard, even when they're like ones and zeros on a billing system. Now, if things can go every which way, you have to test a lot more. You have to run your own evals a lot more. So that's really, really tricky. And then simultaneously, we integrate into over 47 different EMRs. I mean, it's a serious undertaking. We have a very large integrations team, and where we
just to sort of conceptualize the problem, something up to 30 to 50% of all referrals are not followed through. So
right.
It's a massive breakdown in a system of where we suffer from chronic disease. Chronic disease is classically some disease of complexity that requires follow up and follow through on referrals. And in a system where 50% of the referrals fail, forget whether they go to and I think that's all referrals, not just referrals to the perfect provider, which would be even another level of optimization, but it's a monster problem you're actually chipping away at.
Oh, 100%. And it ends up in a situation where the only patients that are really getting care are the ones, and you know this well, right, are the ones that are hyper vigilant, hyper competent. They know exactly who to follow up with and how. And that's just, it's not an expectation, frankly, that you can have for a patient population that needs to go and get care. And I think everybody's got some experience or another of feeling like they've been sort of sent into the black hole of healthcare and are like, I don't know which way is up. So yeah, absolutely. And our belief is that you solve it from the receiver side. Yeah.
Yeah, well, I think you also are really being very respectful of the topography of healthcare as it is. I think so a lot of technical founders say, I mean, I've watched this now 3 times in my career where I'm from outside of healthcare. You're all stupid. Here's the solution. And in some ways, they're right. It is kind of stupid the way things are. And the solution might help at some level, but until you adapt it to the economic, architectural, personal, cultural, and specific topography of how things work, which appears to be the way you're driving this. So what's the so we thought about the patient benefit is they get actually to the referrals they need and they get the care they deserve from a hospital administrator or a doc running a department. This has got to have some impact on throughput and output. And at a time when we aren't manufacturing, we're about hundreds of pro forma hundreds of thousands of more short of the doctors and nurses we need, and a tight restriction on immigration. What's the administrative pickup here? Does this actually improve and expand the ability for workflow for doctors and staff?
Yeah, absolutely. I mean, on the one hand, right, on more nursing and MA staff, there is just insane sort of relief from the clinical workflow side of things, just a lot less work. And then on the throughput side, right, we see very, very significant increases. The sort of median, right, following go live is 17%. And these are folks that say, hey, we have zero downtime. Well, what they often don't really realize is that when you're converting patients that quickly and you can have a nice backlog of patients that are ready to go and you know that they're eligible for service, you've got far fewer no-shows. You got patients getting turned around far faster. And so yeah, throughput is massive. Reduction of denials is really massive on more complex procedures. And then of course, like operating efficiency, it is just there is a lot of room to do a lot more with less.
How are you cracking the denial piece? Because I would think of that as more of a traditional revenue cycle.
Yeah. And one of the biggest things I think that's led to our growth is we've proven our case that over 50% of denials are avoidable up front. And actually, you're going to make the biggest impact when you have the patient on your side, helping you basically get all the documentation that might be necessary to support, especially in an authorization process, or of course, just making sure you have the right insurance at hand. So that's particularly in our insurance benefits manager product, but you can avoid an incredible amount of denials by making sure you have the right payer, the right plan under the right service. So.
And you certainly have solved your problem of raising money. Is it right that you raised about $160 million in a year and a half?
Yeah, that's right. By the way, and I do it. I've never. What I realized, like in the Valley, there's a lot of people that say a lot of things, promise a lot of things. I grew up there, and I was like, I'm never going to do that. I'm just going to say, and so I'm going to say exactly what we're going to do, how we do it, and never really overpromise. And that's been kind of the magic, because then you have an army of people that are really rooting for you and really want to see you succeed, and they're excited to see what you're going to do next. And so that's been. That helps me sleep a lot better at night too.
I'm thrilled at what you do. What are you going to do with all the money?
Look, there's some really unsexy answers and there's some really exciting answers. I'll skip most of money goes into scaling the operation, right? You got to front all the capital required to go and get great, more product and eng team, basically. Like we're pushing on the product eng side dramatically. Look, then the thing that's super, super interesting that I think is maybe worth mentioning is, right, we're obviously taking patients from point A to point B, but we're incredibly interested in helping make sure they identify point C, point D, point E, and F, and so on and so forth. And so we are absolutely taking some very, very big swings at saying, look, we've got this massive network now of, I'm not even sure the amount we've raised really reflects the patient volumes that we're doing, the providers that we have in our network, and saying, hey, look, we have this broad array of providers and this massive.
What would be any names you could suggest of places where you're already established that you can share with the audience?
Yeah. So, I mean, just say, take basically almost any outpatient specialty area, and we'll have somebody in the top 5, right? Whether it's imaging or whether it's ortho. So I honestly got to double check my MNDAs,
That's
but
okay.
right, like on the imaging side,
that's okay.
yeah,
Get it
so
ready
maybe
for the next podcast and shamelessly leverage their brand for yours.
Take somebody like a Rothman, or take somebody like a Simon Med on the imaging side, right? These are massive volume players that are really focused on helping these patients get from point A to point B. So yeah.
How did as we're wrapping up, how do people find out about Tennr other than in your next fundraising?
So we spend a lot of time. We think, look, there's so much fun to be had in solving these problems, right? We think there's a lot of excitement. There's a lot of cool stuff to get excited about. We make these commercials. So you follow us on LinkedIn. We're usually producing like a weird, wacky commercial that you're going to want to tell somebody about probably every 3 to 6 months. You should follow along really on, I would say, LinkedIn. And yeah, we've got a lot of theater kids, a lot of creative energy to outlet that I think people will get a kick out of, especially even just the faxing thing, right? We made a big commercial and splash around like, it's okay to send faxes. In fact, actually, it's a lot faster.
I know we had a little bit of a problem making this meeting happen, but I'm just delighted, Trey, that you're solving the hard problems in really, really novel ways that are going to be benefits for not just physicians and administrative staff, but for patients. With a 92-year-old mom who's got lots of referrals. I hope you're installed in a facility near her soon. And for the audience, if you liked what you heard or you didn't, we'd love you to subscribe to CareTalk on your favorite service. And Trey, thanks so much for joining.